Bismillah Rahman Rahim. Assalamu alaikum, dear students. Today I am going to talk about a very important topic of bomb blast trauma. Bomb blast is injuries to civilian is very common and have become increasingly common during the last decades. And examples of these are the train bombing in March 2004 in Madrid, and there were incidents in the London Underground in 2005, Oklahoma City bombing in April 1995. This is a very important topic because we daily come across, and the key to the management is that we are prepared for these kind of injuries. Actually, the detonation of bomb explosive leads to a virtually instantaneous release of large amount of energy in the form of expanding gases. These gases compress and superheat the surrounding air so rapidly that a shock blast wave is created and damages occur to the human body when the shock wave encounter tissues of different densities. Thus, they create differential pressure forces, motion, stretching, and eventual tearing. Shock waves of low to moderate pressure propagated through solid organ of relatively homogeneous densities generally do not cause significant effect, whereas but if they are high enough, they can result into injuries to the solid organ as well. The hollow organ, they usually containing air, tend to be injured by shock blast waves more commonly, especially the middle ear tympanic membrane and the tympanic membrane and the lungs and the small bowel. So today I'm going to talk about this topic in under three headings. Number one, that the bomb blast injury, as we all know, is a mass casualty incidence, and we need to define what is mass casualty incidence and what are the different types, what are the challenges to deal with mass casualty incidence, and then we are going to talk about the bomb blast that create different damages through which mechanism, and what are the different injuries that the bomb blast will lead to the different organs. And then in the last, we will be talking about how can we manage that and what are the parameters that are to be taken care of and managed in an effective manner. So at the end of this lecture, we will be able to define mass casualty incidents and the unique challenges of mass casualty incidents. And then we will be going to classify the bomb injuries and what are the damages that they would end up doing. And we will be talking about the triage of the bomb blast and understand the difference between day-to-day triage, which we all know, and the triage of a mass casualty incident. And we would be talking about the primary survey, the color coding, which is the hallmark of triage, and then secondary survey. And in the next lecture, I will be talking about the different clinical scenarios that you will come across. So, mass casualty incidence is patients is defined as incidence where your resources are overwhelmed and cannot be immediately supplemented. Triage by necessity focuses on identifying those patients with the greatest possibility of survival. So in mass casualty incidents, we would be trying to identify the patients who needs our most attention, and they have the most chances of survival. Actually, the medical response team consists of at least four healthcare professionals. It is led by acute care specialist that provides emergency medical care and to an individual patient. There are different phases of MCI. Number one is preparation, that we prepare. We identify the risk, we build the capacity, and we identify the resources. These activities include a risk assessment of the area, the development of a simple yet flexible disaster plan that is regularly reviewed and revised as necessary, and provision of training that is necessary to allow these plans to be implemented when indicated. So the patient phase is a very critical phase where we identify the risk, we build our capacity, and we identify our resources, and then these resources and these training will help us manage the disaster. Mitigation means that we would try to divert all our efforts in minimizing the whatever damage has been done by the blast. So it will lessen the severity and the impact of the potential disaster. So this can be done through the adaptation of incident command system for managing internal and external disasters, and the exercises and the drill that are necessary to successfully implement, test, and refine the hospital disaster plan. There is no substitute to educate planning, training, and drilling. And then once we have, we know what the response, when we know what mitigation we need to do, then we will respond to the situation, and that involves activating the hospital who are undertaking the treating victim of the actual disaster. So we are going to phone them, like if this disaster is in the vicinity of Shalamar Medical College, we have our plan of disaster in place. And then when the incidents occur, we will call them and tell them that this has happened. And then in return, the disaster plan of the hospital will be activated, and whatever plan has been in place, they would be, started to act, and that will include the decontamination of the patient, and that will include the formation of triage. That includes our increasing our capacity and capability. And once we have overcome all these, then the recovery phase is that we are able to resume our daily routine, whatever the hospital has. And you cannot keep it for a long, and once the disaster is over and you have managed it successfully, then the normal routine work will be done, will be started, and that the local public health system will be able to take care during your absence there. And the goal is to save the largest number of survivors from a multiple casualty incidents. So whatever we are doing is to identify those patients who requires our immediate attention, and to make arrangement that they are saved. So what are the considerations during a mass casualty incident? That we would need to have a supply, we need to see what is our demand and what is the supply, and we need to allocate the resources. We need to have a coordination, which is very, very important. And we need to define the algorithm of the medical management, and then obviously ethics are involved as well. So for us, the challenge would be that we need to transport the patient to the hospital. We need to minimize the further possibility of another accident, and we need to manage the fire which is there maybe, and we need to manage hospital who is overloading by the casualty that are coming, and then we need to evacuate and make a space for the people who are coming. During disaster trial system, we need to know about the mass, that is, move, assess, sort, and send. Our emergency severity index, sort, assess life-saving interventions, treatment, and transport. And then is the blast injuries. Once there is a blast, then we need to know that I have already told you that blast leads to an instant creation of large amount of energy, and that energy consists of expanding gases, and these gases compress and superheat the surrounding. So the blast injury will lead to a primary injury. That is, once the blast is there, the shock wave will be generated. And that shock wave will be hitting your body, or body of the victim, and that will damage directly. And as I have told you, that solid organs are usually not injured before the hollow organ. So the main burst is on your tympanic membrane, which may be perforated. You have lung blast injury. You can have your intestinal injuries. You can have injuries to the vessels, which are hollow as well. Secondary injuries are those injuries where the fragments or shrapnel from a device that hits you, and that causes the damage to any organ of the body. And once your body is displaced and it hit against a static thing, अगर एक अपना कमरे में हुआ है और आप shock waves की वजह से you hit the wall, and then by hitting on the wall, you would get injuries. This is called tertiary injuries, and quaternary injuries are the other injuries. Like once there might be burns, there might be inhalation injuries, and there might be chemicals there. And these injuries will lead to further casualties. Distance from the bomb is important. If you are near the blast, and obviously you will face the maximum burn. If you are away from it, then the impact of the shock wave would be less. But it also depends upon that whether that blast is inside a closed space, like maybe in bus, in a lecture hall, in a cinema hall, then the injuries would be different. And if you are inside that area, then you will face the maximum burn. Whereas if it occurs in a closed space and you are outside it, then the injuries pattern will be different and you might be saved. There is a unique, blast injury, that is suicide bomber. What happens in the suicide bomber is that, their bomb contains screws, nuts, metal things, and that lets when they blast, these shrapnels will lead you to a major injury, and multiple organs will be involved. And once that bomber explodes, then his bones, flesh, they can also enter into your body, and you can have blood-borne diseases as well. So, and during that blast, uh, catastrophic hemorrhage is one of the more worrisome things. Patient might have traumatic amputation. It could be an isolated injuries, and we need to see the other injuries as well. As I have told you that organ containing the hair are the worst affected. So blast thorax is the major injury, and is almost present in every cases who have tympanic membrane rupture as well. And they could be risk to the great vessels and aortic disruption, and that might not give you any time to resuscitate. Blast abdomen could be there, significant intra-abdominal bleeding and late bowel perforation, even if abdominal wall is not breached because of the shock waves. When you are thrown against the wall or you fall on from the secondary impact, or there is direct hit from the object, you might have pelvic injury. And because pelvic injury bleeds like anything, and it has got a high mortality, we need to see that. So by doing simple things, we can manage that, like applying a pelvic binder, or if there is injury to the vessel, by taking the proximal control, we can save many things, and we by the time to get a CT scan done. The third thing is, once we have that, now how to manage it. We know that what is mass casualty incidents and what are their different stages of mass casualty incidents, and then we know the mechanism of blast injuries. Now we will talk about how to manage that. So triage is a process where we will sort out the patient on priority basis. So there could be primary triage, where this primary triage could be unseen prior to the movement at the hospital, like they could be self-transported to the hospital, or they could be secondary at the hospital, or they could be secondary at the scene if you have primarily managed certain things. So what are the parameters and what are the components you need to do? You need to do a rapid primary survey, that is A, B, C, D, E. And then after doing A, B, C, D, E, that is airway, breathing, circulation, deformity, exposure, then you stabilize. Try to stabilize the vital function of the patient. And then after that, you get the time and you do a detailed secondary survey. And then third is the definitive care. The team leader has a very critical role. He supervises, he checks and directs the assessment. He ideally should not be involved in the hands-on assessment itself. So he would be standing at one side and he would be ordering. He would be asking people to do this, do this, do this, do this. And it is not necessarily that patient is that person is the most senior person, but that person has to be an ATLS instructor. So the triage is the process of prioritizing patient treatment during mass casualty events. Do the most good for the most patients using available. So whatever resources are available, we need to direct those resources to the people whom require our attention. And triage will sort out the patient according to their airway, breathing, and circulation. This triage is a dynamic process. It is not a one-time process. It occurs at multiple time level, like it occurs at the site of the incident. It occurs at the hospital. It occurs at once the patient is shifted on the bed. So it is a dynamic process. The commander who is managing all this should be the highest ranked medical professional on the scene who is trained in disaster management. So it has to be a qualified person. So we will assign different team members the different roles, like we will ask somebody to do the patient assessment. We ask somebody to apply the blood pressure. We ask somebody to take a blood IV line. We ask somebody to document it. We ask somebody to record all the things. So different people are assigned different duty by the team leader. And at the site of the incident, we will have a smart triage pack that includes dynamic tags, that includes dead tags, pencils, time stakes, patient count, card, protocols, and smart padded tape. So how would you prioritize your patient? This prioritization is done by coding. If it is coded red, and then I'm going to explain to you what is red coding. That would be primary. If it is tagged yellow, then it means the patient required urgent treatment. If it is green, then you can delay the treatment and patient might be walking wounded. And if it is black, then you know that the patient is dead. And that is life-threatening injury that requires immediate, right? Intervention or operation, and it cannot be delayed. Yellow is a life-threatening case, victim who can be delayed for a few minutes to hours, and is seen after you have dealt with the red coding people. Green is vocal wounded and has minor injuries. Usually they reach the hospital on their own. And once you see the black, you see a patient who is dead, then you would be labeling them as black. So now what happened is, you know who are the people who requires your immediate attention. So you will direct your team and your resources towards that patient, right? Then there is a people include blue as well. Blue is the one who whatever you do might not survive. He's a severely injured patient. But if you have 2, 3 casualty and the casualty list is not long, then you can include them and allocate your resources to them as well. So how would you know that which color tag is to be given to which patient? If a patient is coming to you walking, then the patient is green, that is priority 3. If he is not walking and his respiration is not there, so he's not walking and you see that there is no respiration, so you try to clear the airways. Once you have cleared the airways, and if still then the respiration does not come back, then you will give them black coding. And if the airway comes back, then you will give them priority 1, that is red, immediate, because उसके पहले respiration नहीं थी. अगर respiration is under 30, respiration is there and it is under 30, then you will check for capillary refill. Capillary refill is over 2 seconds. It means he's bleeding from somewhere. Then you will put them to control bleeding. If it is under 2 seconds, then it means the patient simply has green and does not require that much of attention. And this is the scenario. You can see that there is a scenario at the site and there is a scenario at the emergency. You have to manage that. If you can see, there are wires applied and the emergency, so that only qualified people and those who require will be allowed to enter. Whereas at the site of the incident, you can see that different tags are being applied to the different. So after applying that tax and doing a primary survey, so what is the quick way? Quickest way to do the primary survey is to assess a patient in 10 seconds. क्या करेंगे आप उससे? You can ask his name. And what happened? You will ask, hello, what's your name? What happened? If the appropriate response is appropriate, it means at least there is no airway injury and breathing is not compromised. And the conscious level is there. So it means the patient is at least in the green. Inappropriate response आती है, altered level of consciousness आती है, और दोनों आती हैं. इसका मतलब है या वो येलो में है या रेड में है. इसका मतलब है patient needs to be to higher level of care. When should the transfer occur? The transfer will occur once you don't have capability. अब आपके पास वहां ब्लड प्रेशर अपरेटस ही नहीं है या आपके पास टोनिक क्यों ही नहीं है, तो you cannot keep him there. Transfer should be considered whenever the patient treatment exceeds the capability of the receiving institute or at the scene. Equipment, resources, and personnel भी नहीं है. These criteria take into account the patient's physiological status as well, obvious anatomic injuries, mechanism of injury, and concurrent diseases, and other factors that also affect. So, airway पे क्या करेंगे? Airway is always associated with cervical spine. So whenever there is airway compromise and you are going to deal with airway, always remember that you have to make sure that his cervical spine is intact. You need to clear the airways by suctioning. You need to administer oxygen and you need to secure the airway. And the cervical spine, avoid cervical spine over movement, use appropriate immobilizing devices, and it has to be inline immobilization technique. Breathing can be compromised by tension pneumothorax. It can be open pneumothorax. It can be massive pneumothorax. You can see the flared chest and pulmonary contusion. So you need to see that. Then you need to see the circulation, and if there is bleeding, if hypotension is there, always consider it as hypovolemia. No matter what, until unless proven otherwise. And the first sign of hypovolemia is tachycardia. So you need to check the pulse, and it has to be either femoral or carotid bilateral. Okay? It has to be seen with quality and regularity. It is normal and full mostly, but not necessarily it is normal bulimia. Rapid and thready है, so have to be hypovolemia. Absent है, it means the patient is hypovolemic. Irregular, there is potential cardiac dysfunction. You need to evaluate the conscious level of the patient by asking his name and asking what happened. Skin color needs to be seen as well. And if there is circulation compromise and you can see the bleeding. So the external blood loss is managed by direct pressure on the wound, or if failed, can use tourniquet pressure. But remember, if tourniquet is applied for more than 45 minutes, it can result into ischemia. You need to keep that in mind. And if you have instrument available, you can apply articulate to control the bleeding. But remember, applying articulate blindly will not help you. It might lead to injuries to the nerve. इंटरनल लंग्स, लाइक मैंने अब तो पहले बताया आपको कि निमोथोरैक्स हो सकता है, हीमोथोरैक्स हो सकता है, देन यू कैन डू चेस्ट डिकम्प्रेशन एंड यू कैन नो देयर इज इंटरनल लॉस। पेल्विक बोन फ्रैक्चर है तो पेल्विक पाइंडर आप कर सकते हैं। अगर आपकी ऑब्वियसली डिफॉर्मिटी ऑफ बोन है एंड यू कैन अप्लाई स्प्लिंट एंड ऑब्वियसली सर्जिकल इंटरवेंशन इज देयर। And you need to see the disability, that is neurological evaluation, the patient is level is conscious or not, pupillary size is there, और reaction है कि नहीं है, lateralization sign है कि नहीं, spinal cord injury तो नहीं है. So remember, in an emergency situation, consent is sought after you have given the treatment, not before that. Whereas in other cases, you need to take the consent and then do the treatment, start the treatment. The treatment should be provided first with formal consent obtained labor. Life-threatening emergency does not give you time for a consent. So the summing of the color coding is that if it is walking, it is green. If it is respiration is compromised and airway clearance leads to restoration of the respiration, then it becomes priority 1. Agar respiration under 30 है, under 30 है और capillary refill जो है 2 seconds में है, so then it is yellow. If it is if the patient obeys simple command and you have controlled the bleeding, then it becomes yellow. Then once you have done the primary triage, you will go for secondary triage. Generally, when there is an extended duration of event, तो एक primary चाह रहा होता है साथ साथ, कुछ लोगों का primary चाह रहा होता है, कुछ लोगों का secondary चाह रहा होता है. So once you have given the initial color coding, तो आप उसके मुताबिक पेशेंट को सेकेंडरी सर्वे करते रहते हैं. सेकेंडरी सर्वे में आपको पता है कि क्या कुछ करना पड़ता है. सेकेंडरी सर्वे में हेड टू टो क्लिनिकल इवैल्यूएशन करनी पड़ती है, कंप्लीट हिस्ट्री लेनी पड़ती है, रीअसेसमेंट ऑफ वाइटल साइन करते हैं. बट रिमेंबर इट डज नॉट बिगिन वंस द प्राइमरी सर्वे इज ओवर. So once you have done the secondary survey, you will either shift the patient, make decision to shift the patient, or the tag may be changed differently. Primary survey, secondary survey will never happen once you have normalized the vital signs. And then, you will do Glasgow Coma scale, and you all know Glasgow Coma scale में आप respiratory rate देखते हैं, blood pressure देखते हैं, and different जो है patient का eye opening, verbal response, motor response देखते हैं. अगर तो Glasgow Coma scale और आपका ये blood pressure scale, systolic blood pressure, respiratory rate और वर्बल रिस्पॉन्स जो है वो उसको स्कोर कर लेते हैं. Once that score is in the range of 12, so then it means the patient is green, you can wait, it is priority 3. If it is 11, it is priority 2, and if it is 10, it is priority 1. Remember, aggressive resuscitation is required to make maximum survivals. Then you need to do whole CT scan, use rapid transfer of the patient. The patient bleed current transfer case, it is mandatory to give blood-borne viruses की आपने स्क्रीनिंग करानी है. और अगर आपको ब्लास्ट इंजन में कोई लिम्फ टूटी हुई है या कोई सूजी हुई है तो then you can do fasciectomy at there. And always remember that, whenever you're dealing with these patients, do no damage, more damage. They are already damaged. You do only minimal surgery that is required, that is to control the damage. Thank you very much. Now, I would be sharing to a video as well. Whatever I have taught you, after seeing that video, you would be able to understand it better. Thank you very much.